And we'll be saving lots of time at the end of this discussion for questions from the audience. And finally, I want to acknowledge both our Haluna Health Board of Directors, at least 4 of whom are in the audience tonight, and many of our Haluna Health staff and partners who will be presenting at APHA this week. Some of our presenters are here in the audience, and so I'd like to ask our board members and our presenters to stand for a quick round of applause and recognition. Please stand. Well, we have an incredibly exciting panel for you this evening. Let me begin by sharing with you why we at Haluna Health thought that focusing on innovative partnership models was during this moment in our history, and to share with you how central innovative partnership is to the work that we do. I think it's fair to say, as many of you have been experiencing, this is a moment when our public sector priorities and commitments to robustly support those among us who are in need of food, health, or basic necessities as part of our greater societal contract to one another has been called deeply into question by some, not only verbally, but through shifting federal and sometimes state and local priorities. At the same time, the power of entrepreneurship to bring dramatically new solutions that can scale quickly and achieve structural change has been newly appreciated. And marrying these two trends has introduced a whole new set of stakeholders who have not traditionally, I think it's fair to say, they've not traditionally been at the table when we've sought to make change in the health of our communities. And these are stakeholders that range from schools to faith-based institutions, to financial institutions, and even to clinical health systems. Together, writes author Chrissy James on the importance of partnerships, together we form a necessary paradox, not a senseless contradiction. As everyone in this room knows, though, forming partnerships to harness varied skill sets and talents is the essence of the work that we do in population health. But let's think about this, because partnership is always a word that sounds great. It sounds hopeful and expansive, doesn't it? But we also know, and we have to be honest about this, that partnerships don't always work out the way we originally planned. More than 70% of business partnerships fail, according to Dr. James Kreft from the Center of Third Age Leadership. Kreft coined the business acronym COPP, or the cost of poor partnering. And of course, in the domain of our personal lives, who hasn't seen the cost of poor partnering in a relationship or two that maybe you might be familiar with, or maybe you lived through? But when public and private entities come together with their two different cultures and motivational levers, I think you've experienced there can be even greater miscommunication and misfire if we don't take the time to deeply understand another's point of reference. We intuitively know that partnerships should bring enhanced capacity, expanded opportunities, and more successful outcomes. But we hail from the world of science, and so intuition only goes so far. We are folks that tend to rely on data. So is there any research that can be helpful here? What are the actual correlates of successful partnership? Are there best practices we can and should be deploying when we build our multi-stakeholder coalitions and our global prevention trials? Is there a secret sauce informed by evidence? Well, this evening we're going to explore some of these very important questions. You're going to hear from some of the nation's leading experts in addressing the social determinants of health through innovative, successful partnerships. They will share what they know about the evidence, as well as the best practices that they have honed over many years building partnerships that bring structural change at scale. And now I'm going to introduce them, and I'm going to introduce each person down the line. You can hold your applause till the very, very end, or you can applaud for each one after, whichever you prefer. On my immediate right is Dr. Shoma Stout. Dr. Stout has dedicated her career to improving the health, well-being, and equity of our world. She has worked as a primary care internist and pediatrician in the safety net and as a global public health practitioner for over 20 years. Dr. Stout currently serves as the Vice President at the Institute for Healthcare Improvement and as the executive lead of the 100 Million Healthier Lives campaign, which brings together nearly 2,000 partners in 30 countries to achieve transformation in health, well-being, and equity with an audacious aim to ensure that 100 million people have improved health or well-being by 2020. She also serves as the co-principal innovator for the SCALE initiative, which supports an evidence-based approach to capacity building for communities around the country to accelerate their journey toward a culture of health. Previously, Dr. Stout was the vice president in Cambridge Health Alliance, where she led that systems transformation, and she served as the co-director of leadership development at the Harvard Medical School's Center for Primary Care. Shoma is on the faculty at both Cambridge Health Alliance and the Harvard Medical School, and in 2012, she was recognized as one of 10 inaugural Robert Wood Johnson Foundation Young Leaders for her contributions in improving the health of the nation. Please join me in welcoming Dr. Shoma Stout. Just as an aside, I'd like to say Shoma and I spent the day together working on her incredible transformative partnership, 100 Million Healthier Lives movement, and it's just tremendous and exciting, and I hope you take a look at that. It's really fabulous. To Shoma's right is Patrick McGovern. Patrick is a friend and colleague of mine for more than 10 years. Patrick currently serves as the Vice President of Government Affairs at Gilead Sciences, a research-based biopharmaceutical company focused on the discovery, development, and commercialization of innovative medicines. Patrick joined Gilead in 2010 as a member of the company's state government affairs team and to help lead Gilead's newly created public-private partnership venture called FOCUS, which is where I met Patrick. And FOCUS stands for Front Lines of Communities in the United States. Gilead launched FOCUS in 2010 to form unique partnerships across the country that would accelerate replicable programs that embodied best practices in HIV screening and linkage to care. And FOCUS was so successful that it eventually incorporated new models of HCV, hepatitis C, hepatitis B, and STI testing as well. Patrick took over direct management of FOCUS in 2011, and under his leadership, and in partnership with more than 185 healthcare institutions, FOCUS has driven a systemic change in how people are screened for infectious diseases in the US, administering more than, get this number, 4.3 million HIV tests and 1.8 million hepatitis C tests in the United States. Amazing. In 2016, Patrick assumed leadership of Gilead's State Government Affairs Group, and most recently, he leads the company's policy team. And prior to joining Gilead, Patrick was the longtime CEO of the highly respected Harlem United Community Aid Center, which is a comprehensive service organization meeting the healthcare and housing needs of homeless people living with HIV in New York City. Please join me in welcoming Patrick McGovern. To Patrick's right is Vivian Vassallo. Vivian currently directs partnership development and innovation at Fannie Mae, the Federal National Mortgage Association, which is one of the nation's largest financial services companies, employing over 7,000 people domestically. At Fannie Mae, Vivian is at the forefront of rethinking the organization's understanding of housing as a social determinant of health. She leads the Sustainable Communities Innovation Challenge, which is a $10 million initiative catalyzing new ideas linking housing with health, education, and employment. And she's also responsible for developing a health portfolio within the organization. But that's not all. Previously, as Vice President of Housing at the AARP Foundation, Vivian led a team implementing national interventions, including a $2.5 million impact investment portfolio. At AARP, Vivian also played a central role in catalyzing strategic partnerships and infrastructure for Age Strong, an investment fund that has deployed more than $70 million to enterprises benefiting low-income individuals age 50 and over. Vivian has also worked previously as a managing director of the Milken Institute Center for the Future of Aging. She's a regular contributor to national media, including C-SPAN, Forbes, and Univision. You may have seen her on those outlets. And Vivian has been recognized by the Embassy of Spain, receiving its Young Hispanic Leader Award. She's also a recipient of the Young Hispanic Corporate Achiever Award from the Hispanic Association of Corporate Responsibility. Please join me in welcoming Vivian Vassallo. Okay, and last but certainly not least, to Vivian's right is Jake Siegel. Jake is the Vice President of Advisory Services at Social Finance, which is a nonprofit organization dedicated to mobilizing capital in order to drive social progress. Jake leads the firm's California office. In his role, Jake works with state and local governments, foundations, and nonprofit service providers to assess and design the potential for pay-for-success projects. He is working to use pay-for-success models to improve the social determinants of health, build safer and more engaged communities, and forge a stronger link between program performance and payment in the service of building a more thoughtful and effective social sector. Jake's work at Social Finance focuses on public health, criminal justice, and workforce development. Prior to Social Finance, Jake was a case team leader with the BridgeSpan Group, where he worked with a variety of nonprofit and philanthropic organizations focusing on impact investing. And in that role, Jake served as a facilitator for the U.S. National Advisory Board for Impact Investing and was a lead author of the board's report, Private Capital for Public Good. Please join me in welcoming Jake Siegel. Okay, so let's dive in. I want to start by exploring the context in which we create public-private partnerships and some of the larger societal forces that directly shape the types of partnerships that are being created. And when I talk about these forces, I'm really thinking about accelerations in technological change, so the mobile revolution, robotics, artificial intelligence, those types of issues, but also big data, demographic shifts, and finally, one other very large shift, which I might call the Amazonification of customer service, which is this 24/7, need for effectively reaching the consumer and serving the consumer. We can see some of these shifts impacting novel partnerships in the healthcare sector. For example, CVS's decision to open Minute Clinics in its 10,000 pharmacy locations, or to buy the insurer Aetna. We can see the introduction of Amazon and Berkshire Hathaway into the public space. So how do you factor these large shifts? And when I say those, I'm really thinking about the technological, the demographic, the consumer, into the public-private partnerships that you are setting up and designing, and particularly when you think about the public and private piece of that. Why don't we start? I'm going to start with you, Shoma. Why don't you take the lead and share your experience there?
Sure, happy to. So as I reflect on some of the opportunities in this space, as well as what I think might be, at this point still, rather developmental possibilities, one of the things that I think we don't account for well is that we, whoever we are as service providers, only reach people a tiny portion of their lives. For instance, if you happen to be someone who is a primary care clinician and you're caring for someone with diabetes, you're going to see them for 15-minute visits a year, an hour, and they're going to manage their illness for 5,000 hours. Someone who is in the public health system may be influenced by the policies of public health, but may not directly reach someone at all. And there's somewhere in that gap is a wealth of opportunity to support people where they are and to be able to actually understand how they're doing. That I think is a real opportunity in looking at how technology can help support this. And I'll give you a couple of examples. Big White Wall is a technology that was developed actually by a social entrepreneur who'd had a family member who had suffered from mental illness. And I don't know if you've noticed many mental health professionals that are available at 2 a.m. when you're really having your thoughts of anxiety or depression. But there's a huge mismatch between the availability of the supply and the need for the demand. And we could, of course, do interesting global partnerships where those who are, up on the other side of the hemisphere are reaching people. But Big White Wall was an innovative strategy that actually suggested that people could support one another. So they created a simple platform by which patients could connect with one another, a wall is always monitored by a health professional, and you can begin to actually support. So flipping the model of how care is delivered. And increasingly, they found that supporting this not just with other patients, but actually Second Life anime characters works really well. Flo is an example that's used in the UK, who is named after Florence Nightingale, who is an AI-based nurse who is interacting via text message with people. And when you listen to how people that Flo is interacting with, who all know that she is not a real person, they feel she cares about them. Some of them think she's sassy in a good way. I mean, they form a sense of relationship. And what they also say is, we know she's not real, but whether it's that or Jane in Project Red, but actually it's much less anxiety provoking to ask my dumb questions 4 times of someone that I know isn't real, but knows me well enough. And that's the key. It's these technologies that are able to learn how to know someone well enough to be able to really support them, and are backed by well-developed algorithms, such as the one CVS Minute Clinics are using with incredible success. Where I think are some of the pitfalls in that we in public health need to engage in is, what's the data that's feeding the AI algorithms behind those systems? So the big data systems bake in the inequities and the structural inequities and the biases of the system we have. So examples of systems that predict, for instance, that are being used around predictive policing and sentencing, bake in our history of structural racism and can actually perpetuate those inequities. And I think this is where, for the person who is building the technology, they're not going to have the context to do that. And it's actually why it's essential that we in public health partner. So I think there's opportunity, but it requires actually for us to lean into the partnership, to recognize that it's not going to be business as usual. But if we're going to figure out how we care for people well past what we're currently able to do in the system, that we too have to be willing to innovate and learn and partner and assure that a safe and equitable system is available.
Thank you. That's wonderful. Patrick, it's a nice segue to, you and I worked in many an emergency room trying to innovate and change their sort of data practices. Even sort of the basic issue of putting a standing order for an HIV test, all of the storm and drang that went into that. How do you, in the partnerships now, as we've evolved 10 years down the line, how do you use these changes to your advantage in partnership?
Yeah, so a couple of ways. But I really like the idea of flow. I probably wouldn't need as many bartenders as I've had in my life at 2 in the morning. She's great. If you think back to where HIV testing was in 2010, routine screening was pretty controversial. We had all kinds of people who felt that you have to do extensive pre-test counseling and extensive post-test counseling every time you deliver a test. And this was despite the fact that we have really good treatments for HIV, but we were still testing people as if we were back in 1988, 1991, 1993. So we encountered a huge amount of resistance, attitudinal resistance, passion about needing to do testing in that manner, but that's not scalable. And yet, we were diagnosing people over and over again, especially in communities of color, who were being diagnosed concurrently with an AIDS diagnosis. So you find out you have HIV, you also find out that you have 50 T cells. And you've been living with that disease for 10 years, and now your own clinical outcomes won't be as good. You're more likely to have infected other people unknowingly. So what we then looked at was, okay, how many times were these people who were being diagnosed so late actually passing through our healthcare system? And the answer was not often. So you couldn't miss that one opportunity to test them when they passed through the ED. But if you were going to test in that old way, with the oral rapid test, and with somebody rolling a cart through the emergency department and spending 20, 25 minutes with each person, you're not going to take those opportunities. You're going to miss them. And a couple of things happened. A testing technology became available that allowed you to uncover HIV quickly, easily, and cheaply within 7 to 14 days of somebody's infection. At the point when they're most infectious, so you can't tell them they're negative because you're using a less sensitive test, it's important that you're catching that disease as early as possible for the individual and the public health. But this test technology wasn't available readily in most hospitals and most labs. We were able, because we're a private company, to move quickly and nimbly, much faster than the hospital systems could otherwise have, and enable these hospitals to purchase this lab equipment. Now it's standard in every hospital lab. But then electronic health records started to really improve over time, because if you're going to test this many people to catch that one person, it's got to be fast, it's got to be easy, and it's got to be cheap. And so you have to be able to be sure that you're testing the right people, you're not over-testing people. So we're able to work with the partners, and this gets better year over year over year at using algorithms in the electronic health record to determine in advance who should be tested and who should not be tested. And then now even at the back end, you can use those algorithms to determine that this person should get that post-test counseling, but that person doesn't need to. So in that way, the technologies have really been able to advance and sort of quiet that debate that used to be raging back in 2010. And now this is really becoming standard operating procedure across most of our healthcare institutions.
Thank you. That's great. Vivian, I would expect that both demographics and data truly impact housing partnerships and how you're using those shifts.
Absolutely. As one of the housers on this panel, I like to say that housing is the prescription for health. And how can we ensure that people have good health by having good housing? We see tremendous trends in the aging demographic in our country. I think most of us has heard the statistic that 10,000 people a day turn 65. We're now a country of more older folks than younger folks. And what impact does that have on both our health and housing? We're seeing technology as a vehicle to bring some solutions to that. We're seeing a lot of advancements in in-home sensors and how that information can be translated back to the healthcare provider for older people as well as for younger people and children and families. With AI, I'm thinking of Flo's friend LEQ. LEQ is an AI-enabled technology based out of Israel that is just launching in the US market. And LEQ provides reverse AI. So LEQ might say to someone living in the home, it's Wednesday morning and it's a sunny day outside. It might be a good day to call your friend Betty and go for a walk. Shall I call Betty for you? And it's really getting to, really anticipating some of the needs and ensuring that people aren't becoming socially isolated and really being able to track some of that. And while some of that may sound a little bit scary and big brother-ish, there's also potential to really bring some of that data back to medical providers to ensure that people have healthier outcomes. I think one of the challenges with technology and housing and health is that you're talking about two data sets that have a lot of privacy associated with them. And so ensuring that both the financial and housing data is protected as well as the healthcare data is protected, and finding out ways in order to integrate them and that protects the privacy of that consumer or that patient is one of the things that I think we have yet to figure out.
Oh, thank you. Jake, building on that, I think, social finance uses data in very innovative ways, actually paying for the performance based on the outcomes data that is received. Are you using either AI or big data in different ways in your partnerships, or how do you use them with local governments when you're setting up these contracts in a new partnership?
The short answer is not much, right? And in part that's based on the challenges that Vivian mentioned in terms of accessing, integrating, and then using substantial amounts of public data, right? We have enough challenges when it comes to actually just getting the data we need to get these contracts done, let alone getting enough of them that we can actually productively put them through AI. The kind of bigger changes, the kind of sea changes that I would call out are actually not technology, right? I think our three brilliant panelists have talked about technology and AI. There are some other challenges or changes that underlie a lot of these things that aren't as obvious. The two that I thought of when you brought up this question are shifts in accountability practices and shifts in how we think about impact. So accountability practices is, this group of public health folks. What I'm talking about is value-based care, which is a part of I would say, a longer arc of government accountability. Government's taking on the idea that actually we should be measuring and paying for outcomes more over time. I don't know if many of you have read the article and then the book, Moneyball for Government, but it comes out of Bush's DPC director, John Bridgeland, and Obama's OMB director, Peter Orszag, made the claim that about 1% of all government spending in the US at the federal, state, and local level was based on any strong evidence that it was creating impact. Right, so that's pretty underwhelming number, but I think there's a trend, right? And we're seeing this a lot in the healthcare space, but not just in the healthcare space, of trying to improve accountability practices, of actually trying to pay for impact as it's being created. So that's one, I would say, sea change that we're seeing, which I'll kind of bring back to technology in a minute. The second one is an impact revolution. I'm stealing a quote from one of our co-founders, Sir Ronald Cohen, who believes that increasingly there's this world of impact investors, and I'll define what the heck I mean by that in a second, but a bigger and bigger group of people who care not just about what kind of returns they're getting for their money, but also what kind of impact they're getting for their money. And this is fundamentally a demographic shift as much as an ideological shift, right? $40 trillion are being transferred to primarily women and millennials who care more about the intersection between returns and impact. And as they do, the way in which investment is being placed into various kinds of vehicles is starting to change. And that's what enables things like my organization, which essentially is building markets around improving human outcomes. Without the impact investors, this could never happen. I would say just one last thing that I promised I wouldn't talk about technology, but all of this is fundamentally based in some degree of technology, in that being able to carefully articulate baselines and also the impact that is being measured in our deals is fundamentally a product of the technology revolution, in that we have to access a lot of and integrate a lot of data that 30 years ago would be nearly impossible to do.
Great. Thank you so much. I want to shift gears for a minute and talk about evidence or research that maybe informs the front end of partnership creation. So we spend a lot of time talking about evidence or data for outcomes. But one of the things I think we could borrow from our friends in the organizational development literature is what are the correlates of a successful partnership? What is the data that tells us what makes a partnership successful or not? And I'm wondering if some of you may have looked at this in a variety of ways, either outright looking at the research, or you may have used data to inform how you shape or alter your partnership over time. And I know, Shoma, we spent the day together in such an interesting and different way of partnering today. And I know that there is some research that informs that. So maybe you could lead us off and tell us a little bit about your thinking when you bring together 100 million and how that's informed by evidence and research.
Sure. So maybe I'll start by actually talking about what do we know about what creates good partnerships. And there's certainly stuff in the organizational development literature and a wealth of knowledge in collaboration. But there's some key ingredients that I think are especially important to think about when partnering across sectors in particular, or groups of people that don't have the same operating assumptions of one another. And really, I think the way to think about it is it's like any other cultural competence endeavor at the beginning. So first you have to actually know what each person cares about, just what matters to them, who they are, where they come from, what are the assumptions by which they operate in the world, and what are the constraints that they have in the way they think about the world. And, often we in public health start and end things with whether we have the same values, but actually what's even more important in bridging partnerships across sectors is where is there a shared interest and an opportunity to do something together, and in the places where there isn't a shared interest, is that likely to take you away or undermine your core mission? And the second, once you've identified whether there's some common interest, it's actually understanding, are your ways of working together compatible? And that's both, like, are you nice to one another and in the way you operate, but actually it's just as much what we call the norms of collaboration. How do you interact with one another when something isn't going well? What's the time frame that you need something to happen by? What are your base assumptions of what you really need to happen out of this process and by when? And getting clear on those more operational things often saves what we call our, we have these whole touchstones of collaboration that really help us to sort of get to an understanding of how to set that table in the beginning, but also how to resolve challenges when they come much, much earlier than we might. So I think that the more that we can have a clear understanding of what the relationship needs to be for it to be a successful win-win on both sides, it can often lead to very durable partnerships between groups that may seem like they don't have nearly as much to do with one another as you would think, but can be very enduring.
Great.
Could I just add one
Sure,
thing to
please.
that? Because I think when I hear you speak, totally agree, and I would add lexicon is very important.
Yes, getting to
We
train.
are a housing finance company, and for the first time in an 80-year history, are engaging with practitioners in health. And the language that all of you all are speaking here at this event around public health is very foreign to me, and if I were to start speaking in housing finance jargon, it would be very foreign to you. So I think in addition to that, what I would add is really understanding that when you're working cross-sector, that really understanding the vocabulary, the lexicon, and the processes and systems of your partner before you can begin to think about working collaboratively is really important and often leads to confusion or mistakes or misunderstandings along the way. So getting that established and continually bringing it up and talking about it is very important, seeking to understand the others.
I
Yeah.
think Woody Allen said half of life is showing up. I think the other half is vocabulary.
That's right.
The word
Sharon.
equity is a little different. in
Yes.
the
They
housing
used to say in
conference.
HIV, when you've learned all the acronyms, it's time to get out of
Yeah.
HIV. Because, speaking of lexicon, the finance world is filled with a kind of different culture, different understanding, and as these financial institutions start to partner with governments and population health professionals around health outcomes, there are really different cultures there. Can you speak a little bit to that and how you...
Yeah, I was actually just going to build on the same point that's being made. Fundamentally, partnerships are about trust, right? And I think one of the macro challenges that we face in the kind of pay for success, social impact bond world is a long-term erosion of trust across different jurisdictions at the horizontal level, so across agencies and across jurisdictions, certainly across the different realms in which we work, which are governments, nonprofits, and investors. And in order to rebuild that trust, I think we need not just communications, which are a central part of all partnerships, but also trying to rebuild credibility in the way that we are talking to one another. So it's not just partnership as a kind of let's all get around a table and talk sometimes. It's partnership in terms of shared accountability, right? Of saying this is what we are going to do over this period of time, and this is how you can hold us to it. So what we do, and maybe I should have started. How many of you folks in the audience have any idea what the heck I do? Have you heard of Pay for Success or social impact bonds? All right,
Raise your hand if you've heard
a
of
chunk
Pay
of you
for
have.
Success.
All right.
Oh, look at that.
Wow, all right, I'm impressed. So fundamentally, we actually think the contracting process has some importance in its own right in building partnerships, because it forces you to do some of the translation, and then maybe more importantly, it forces you to have accountability for what you're going to do and what you owe to one another. All right, so it's building something around a shell, around a core that lays out the roles and responsibilities, not just what everyone will do, but how much those things matter in terms of shared financial accountability.
Yeah, go ahead. Go
I
ahead.
was going to go on to a different track, so if
Keep
you have
going.
a question, go ahead.
No.
All right, the other thing I would say is that, if the contracting is one thing, that's the kind of the wheel maybe, and the axle is the governance process, right? The thing that actually makes all of this go is the mechanism by which we all kind of look at data on an ongoing basis, agree on what's happening, and then troubleshoot to try to improve outcomes over time. Right, so building these really tight, collaborative, shared partnerships that have financial incentives baked into them, we found has been the kind of secret sauce in the whole thing.
That's great. I did want to build on that because when we talk about public and private partnerships, the cultures in a public entity and in a private entity are very different, and some of that is driven by the motivational levers and the incentive levers that there are in those two institutions. And one of the things, Jake, you just sort of mentioned is that the contract itself sort of can bring those two motivational align them in a way that you wouldn't think, perhaps, necessarily. I wonder, maybe the rest of you can speak to how we bring the public culture and the private culture. Where are there similarities? Where are there differences? And how do you use those to forge your partnership or to navigate through a difficult spell that you're having in a public-private partnership?
Sure. So what I was thinking of as you were talking were a couple of examples of where things have gone well, so that we can work backward perhaps and think about what we can learn from them. So one rather enduring partnership is between manufacturing sector in Wisconsin and the school system in Wisconsin. And you wouldn't think these are the most obvious natural allies, but actually they have some shared interest, because often youth graduate and leave the community, which leaves the community with not enough of a workforce to be able to staff places. In addition, the schools are struggling to make sure that all the kids graduate and do well. One of the things that they found was an area of shared interest, which then required the building of relationship and trust, was instead of actually having the manufacturing industry train youth in the schools while they're still in school in operating precision machinery that they would then be using while they're at work. And what's exciting about it was it allowed the school to get to like a 96% graduation rate over time, with guaranteed jobs for all kids that were not college bound, which is actually really important. In addition to that, it saved the companies a tremendous amount of money, because instead of paying someone while they're on salary to train them and or not having a reliable workforce, they could train someone, they could actually know who this kid was before they got there, and it actually took a lot of inefficiency and cost out of their process. So because there was really good alignment there between the wins, you could make something work. And another example, there are 5 counties that came together across philanthropy, the private sector, and the health sector and community-based organizations to actually create a funders collaborative across 5 counties to address poverty. And in that collaborative and setting, at the first part of it was really getting to agreement that actually everyone had independently in this place that had a low employment rate, high poverty rate, had tried unsuccessfully, and they needed one another to get there. And they created a period of learning, which I thought was really brilliant, of about 2 years where they agreed that they were going to learn what was possible. They were going to integrate improvement science. It was called a POINT initiative. And there's a nice case study that you can read about. And as they did that, they began to discover each other's assets. And at first, what they thought it would be was, these people would just give money and these people would get money and that's all it would be. But actually what they learned to do was build coordinated employment systems for returning citizens who were getting stabilized in nonprofits and could get into business as well. They developed, the businesses took their quality improvement people and gave them to local nonprofits as volunteers to actually support them to build their data infrastructure so they could have what they needed to get to outcomes. And everyone agreed to join accountability for outcomes, but they did that in the context of an environment of learning where they could really get there. And after they did that for a while, they found the places. They wanted to work on ACEs, they wanted to work on job pipelines, they wanted to work on the incarceration rate, and began to bend those curves. And I think one of the things that we sometimes don't build in time for is a period of learning, both about one another, about assets, but also what it looks like to leverage the known and unknown assets that might emerge from the process.
That's really fascinating, because when I apply what you're saying to Patrick, our work in New York, and the regional, you had a very brilliant idea to have these sort of regional leads, team leads, who embedded themselves in all of the different organizations, whether they were public health departments, CBOs, hospitals, to understand their process around HIV testing and to understand what their challenges were, and then perhaps bring it back to you. So maybe you could talk a little bit about the cultural learnings that happened across the different sectors there.
Yeah, so I think it wasn't my idea, but I do think it was a brilliant idea to put these, these public health folks that we employed into the communities, working with each one of these, federally qualified health centers or hospital systems to really be there, not quite on a day-to-day basis, but with real frequency, to understand those internal workings and those internal relationships, and sometimes to even build the relationships within the institutions, because you'd be surprised that the head of the ER doesn't often talk to the head of primary care. And none of them want to talk to the lab director, but the lab director controls a lot of power because he drives a lot of revenue. So the regional lead, our employee, who usually came from a health department, would be very much involved in the inner workings of that institution to try to make this work, because it only works if nursing's bought in, if the ER docs bought in, if the IT folks are bought in, and if the lab director's bought in. And mostly those folks don't talk to each other. So it's sort of building a sense of shared passion for this task, routine screening for HIV amongst all those parties. And usually it was one of the patient's stories that did it. It was one of those patients that you would have missed otherwise, that you diagnosed and got in time, and sometimes just in time, that would get all of these parties together. And then I think the real secret sauce, if I could go on a little bit more, the real secret sauce was breaking down the mistrust between the institutions. So I don't believe in, dissemination in publication time. I'm not interested in something that's going to get published, that you did today that's going to get published in 3 to 5 years. And then you have to rely upon somebody picking up that journal and then knowing how to operationalize it. I'm too impatient for publication time. I like real-time dissemination. And this regional lead would be able to say, hey, your CQI figured out how to solve this operational challenge here in this hospital. Would you share that practice with this hospital over here? And everybody wants to share when they're successful. Nobody wants to share when they're not successful. But we were able, because there was a shared vision and a shared passion, to be able to get institutions to share data in real time and create an iterative process in real time, so that an institution here is learning from an institution there. And that accelerated the development of the model. It was just the way it worked. That was the secret sauce, that iterative process, getting people to share data in real time to solve immediate problems.
Thank you, that's great. And I think you mentioned something with respect to buy-in, but buy-in either within institutions or between institutions. And sometimes it can be within institutions that is the biggest challenge. We started this sort of set of questions around public culture and private. Sometimes it's within the same institution. Maybe you could talk about your experience obtaining buy-in for the partnerships that you've been involved with across these different sectors.
Sure. Are you talking to me? Okay. Yeah. I think that, at Fannie Mae, we're very lucky in that our leadership was the catalyst for the Sustainable Communities Initiative at the company, recognizing that housing is multidimensional, and so therefore figuring out how we can be more connected to education, employment, health, and other sectors. The buy-in, it's really helping my colleagues understand how this is going to impact them, and getting to just the same thing we're talking about, building the trust, identifying the shared goals, how we're sharing data. I did a brainstorming session that was enterprise-wide, and it was the first time that some of my colleagues had come together, and they're working on very similar things but in different areas. So really understanding how all of that feeds into that ultimate goal and that shared goal within the institution. I think having the buy-in from the top is great. In a lot of instances you don't have that. You're trying to get that buy-in from your leadership. I think in our situation we're very lucky in that that is coming from the top. It's in our board and it's in our leadership, and therefore it's a priority, I think, across the organization.
Yeah. I think, Jake, I want to ask you something a little unique to what you do. There have been two new, really interesting, dare I say it, interesting pieces of legislation that have come about that are driving new types of investors and investments in what are sometimes called distressed communities, but I like to call them communities with great capacity for resilience. And these are the Opportunity Zone legislation from the change in the 2017 tax law, but also the $100 million that was put into the congressional budget for pay for success projects. How do you see, using these new pieces of legislation? What should our audience be aware of and be thinking about in terms of building partnerships that can harness some of the exciting prospects potentially of these two new pieces of legislation?
It's a good question, and we still don't know the answer yet, but we have some thoughts at this point. Right? They're two pretty distinct pieces of legislation. So have folks heard of opportunity zones? I'm doing a whole hand-raising thing, apparently.
They've got their drinks in their
How
hands.
many people have heard of opportunity zones? Raise your hand. About half, I would say.
Okay, so opportunity zones are a new wrinkle in the tax code that will enable folks to invest in certified opportunity zones, which are communities with significant capacity for resilience, if you will. And they get preferential treatment on capital gains. At this point, we don't know exactly how this will play out. We do think it will be a significant change in the way that we are able to invest in community development. Right, this is the first major change in community development finance in the last decade or so. At this point, the regulations don't really specify how or to what extent outcomes will actually have to be measured. So that will be a pretty important driver of how this is really implemented. But it definitely drives more investment capital into the communities that we're discussing, and will be a major change coming through the community development finance world. Let me put that aside for a minute, because most of my work is on the other bill. Most of my work is with another chunk that came out of legislation in early 2018. And this is the SIPRA bill. It's the Social Impact Partnerships Pay for Results Act. I got it right. My work is done. This is a $100 million piece of legislation that creates a fund within the U.S. Treasury in order to create matching outcomes payments for pay for success projects. When I say matching outcomes payments, I mean Treasury will release an RFP end of January, early February, in which state and local jurisdictions can apply for some pool of outcomes payments as long as they put up some of their own. So for one of the challenges that we face when we come back to partnerships is distributed or diffuse costs, right? And healthcare is a classic one in that if we're talking about the Medicaid population, for example, there's an FMAP. So the feds get some of the potential value creation via prevention, and states do as well. So opportunities like matching outcomes funds coming out of Treasury give us an opportunity to unlock some of that, some of the value that's being lost today through diffusion. Right? So it lowers the bar for the kind of activation energy, to mix all of my metaphors, needed for these kinds of pay for success projects. So we think this is a huge opportunity in that they'll be releasing an RFP in a couple of months that will give access to $100 million for states and local communities to do things that they otherwise wouldn't be able to, right? To actually pay for outcomes with some support from the feds. So massive kind of sea change coming in the pay for success world in the next few months.
That's great. Thank you. We're about to go to your questions, but before we do, we're going to do a rapid fire round. You mentioned, Jake, the secret sauce. So here it is. This is the secret sauce question. If you had to identify, we're going to start with you and come back around. If you had to identify the top 2 to 3 elements that you would term best practices that make for the most successful public-private partnerships, and particularly if you can think about those that bring structural change to population health, in your experience, what would those 2 to 3 elements be?
I mean, I'm going to repeat myself a little bit, but shared governance, financial accountability, and access to administrative data by which we can track outcomes and troubleshoot and kind of make changes along the way.
Beautiful. Vivian?
I'm going to say trust, just as a good foundation in any partnership. Evidence-based data sharing, I really like this period of learning to really have that be based on data and evidence. And then I would add as a final the ability to surface failure as it's happening, and when it happens, knowing when it's time to walk away.
That's a good one. Patrick?
I think number one, trust based on a shared passion or a shared vision. I think number two, it's the willingness to be wrong, take risks and think big. We had to be very willing to say no as much as we said yes, and we had to double down on a methodology that some people thought might be wrong. So being willing to double down on your instinct that you're right. And feeling that you're right because you're working with the right people that you trust because of that shared vision. And then I think the third thing is that iterative process. We have to be continually learning from each other across sectors, across competing institutions. We have to be willing to share what's not working in order to also really share and incorporate what is working. And that iterative kind of process, I think, is really essential, and not publication time.
Thank you. That's hard for an audience.
I know.
I agree with everything that they've already said, and that on trust, on learning, of failing forward fast. These are all core approaches we use in 100 Million. But the two others that I would add to those is the ability to start by setting an audacious goal and working backward from that to say, how might we, to at least give ourselves a space to say, how might we achieve this if we brought our assets together? What's needed? And how might we use what we have in both traditional but actually non-traditional ways to solve the problems that each other have and that we have? And a really interesting example of this that comes from the economic inclusion work on anchor institutions is, in our Pathways to Population Health framework, we're challenging healthcare organizations to not just, and businesses, to not just look at the care delivery lever as the thing that they do. Of course, that's the traditional thing they do. But healthcare employs 10% of people in the country. It actually buys a ton of goods. And so when healthcare takes its levers of employment, purchasing, investing, food sourcing, et cetera, and takes an equity lens to that to map the places that have the poorest outcomes and begins to think what they can do differently about that, some health systems are infusing hundreds of millions of dollars to essentially do what opportunity zones are intending to do, to take a legacy of redlining and convert it to greenlining. And I think that's the kind of out-of-the-box thinking that isn't about doing something extra because it's nice, but about changing your core operations strategically to achieve impact across sectors that I think we have the opportunity to learn our way into.
Beautiful. Thank you so much. Can we first have a round of applause? We're going to open it up to not only our folks in the audience. You'll see Peter and Linda on our team walking around with microphones. And we also, if we have questions from our live stream, we're happy to take them now. I see a question in the back. Yeah? Oh, go ahead, Linda. Why don't you start? Okay.
Hi, thank you. My name is Michelle Edison. I'm with the Mahoney County District Board of Health in Youngstown, Ohio. I run the Mahoney County Community Pathways Hub. We do use that sort of a pay-for-performance model in that we have community health workers that engage those that are most at risk for poor health outcomes. We actually in Ohio contract with Medicaid managed care plans who will then pay the hub for those outcomes, specific outcomes based on our strategy called Pathways that our clients achieve. But we're also seeing that especially for my hub, where we focus on reducing infant mortality. Ohio has one of the highest infant mortality rates in the country, and our county has one of the highest in the state. We're seeing that that model still isn't sustainable. Right now, we're really highly grant funded, especially for our community health workers. We've received funding where community health workers are put into these positions for a year or 2 years. It takes that long to really get them up to speed and trained, and then the funding is pulled. And so we're looking at how do we engage these private partners, how do we make them interested in these population health, community health issues, in order to make it sustainable, but also in order to make it work for them as well as for us.
Thank you. I'm going to try to summarize that question really quickly so everyone can hear. I think the question really is, when you have something that is starting to work, how do you engage some of the private sector to build sustainability for that population health activity, and how do you keep them engaged and interested? Shoma, why don't you want to take that one?
Yeah, well, the Pathways Hub model actually it achieves a 50% improvement in birth outcomes. It's actually one of the ones in 100 million we've prioritized to scale up. So I think what we should do is talk to Jake over there about how under CIPRA we could use that legislation to test out what it would look like.
Great. Thank you. Over here?
Hi. Hi. I'm Rita Kavahara. I'm with the Association of Asian Pacific Community Health Organizations, and I'm working specifically on health policy related to hepatitis B. And one thing is, within the opioid epidemic, we've seen rises of hepatitis B of up to 100 to 400% in states like Tennessee, West Virginia, Maine. And the question is, when we have an adult vaccination coverage of only 25% nationally, but we have an effective vaccine that has no cost sharing for patients with private health insurance and Medicare, and the same thing for Hep B testing. Why aren't we able to turn that into a national hepatitis B adult vaccination campaign or testing campaign in a similar way that HIV and Hep C testing have become so routinely integrated into primary care? And also, how do we speak to the internal medicine and other communities in order to really emphasize the Hep B part? Because I have a clinical background and know that I talk to my patients about the flu shot, shingles, pneumonia shot, but Hep B vaccine just doesn't come up.
Thank you very much. So this is for Patrick, clearly. The question is really, how do we expand and nationalize, in a way, hepatitis B to the extent that we have HIV and hepatitis C?
Yeah, like the other two, it's a highly stigmatized disease. So, we have to get beyond the stigma. And I think one of the ways to get beyond stigma in preventive health is to routinize. We routinized HIV screening. We simplified the processes. We used a lab-based blood testing technology that's fast, easy, cheap. That same model can be used for HCV, for hepatitis B. It's more complicated with hepatitis B, but the EHRs are getting so sophisticated so that they can actually streamline that process of determining who should be tested for hepatitis B, and then what the algorithm for testing is. It's pretty complex, as you know, but it can be done. And in Appalachia, where we have now testing in, I think, 112 sites, we're doing HIV, hepatitis C, and hepatitis B screening. And again, it's just using that same process. It's very streamlined on everybody getting a blood draw, and we're finding startling seropositivity. So, one of the great advantages of routine screening for hepatitis B is it also tells us who should have been vaccinated and who still needs vaccination. But it's an area that I think will be significantly expanding our efforts. And then hopefully we get a cure. We also have a robust cure research program at Gilead. So fingers crossed that within the next 10 years or less, we'll have a cure.
Great. Any final questions? Yes, right here.
My question is regarding algorithms. We talk a lot about algorithms and AI technology, which is great and phenomenal and is going to be amazing in the future. However, it can miss things. It doesn't tell the whole story. At what point are we over-relying on algorithms to point out problems instead of looking at the whole human, complicated picture?
I think that might be for you.
Sure. I actually don't think you should rely on algorithms. There are a few algorithms. It's been tested over and over again, and that's tens of thousands of times where you can say, okay, this is the positive predictive value and the negative predictive value of this algorithm. But there isn't, I think, there isn't a reason to not take a look at the whole person where that makes sense. Now, where do I think algorithms work fairly well? Well, it's where, a set of symptoms you have a runny nose and you have a sore throat, you probably don't have strep. You don't need to get a strep test. So those things that it's very likely that something is one particular way. And it should make it possible for the patient who knows something more about themselves to be able to say, I disagree and I'd like something more. And I think that is where that should always trigger that kind of thing. But for more complex things like chronic disease or what's happening in life or the intersection between different illnesses, that's where things absolutely fall apart. And it's why I always tell healthcare professionals, my story about flow notwithstanding, I think you don't have to worry about your job security because people still value the relationships and the opportunity to be known by someone who knows all of who you are. And as a primary care clinician, I certainly feel that way.
Great. Any other final questions? Last questions.
Limited utility.
Kimberly.
Yes. Hi, my name is Kimberly, as Blaine said. And so I think in public health, we've done a really good job, with coalitions and bringing different partners to the table. But I think where we still struggle is that financial piece. And so I was just hoping you could share some insight about, who might we invite to the table to help fill that knowledge gap in order to garner more buy-in when it comes to social impact or pay for success models, which are complex and difficult to achieve if you don't have that knowledge.
Thank you. I'm going to have Vivian and Jake. Why don't you two
Sure.
take that?
And just to get started, so I think that one of the partners you can begin to incorporate into the conversation are finance professionals in your community, whether they're lenders, developers, builders, borrowers. They also have a strong stake in the health and well-being of the residents in the community. We just launched a pilot this year called Healthy Housing Rewards, and we're partnering with two nonprofits, the Centers for Active Design and the Stewards of Affordable Housing for the Future. They're helping inform both active design that has healthier outcomes and enhanced resident services in a housing, in this case an affordable multifamily rental housing community. And so we've gone out and sought these partnerships with those practitioners. I would say to those in the public health field to look in your community at who's providing the housing that your patients, clients, consumers are housed in, and think about ways to layer finance through them. The models don't necessarily exist yet, but it's through these conversations and understanding and through organizations like our company that are beginning to pilot and explore where are the opportunities. And I would say in addition to that, the way that the health sector can help the housing sector is through the measurement of the outcomes. So we look at ROI in a financial perspective, it's pretty clear and cut. With the social ROI, it's a little bit more difficult, and with the health outcomes and measuring that through financial partners, we want to better understand how we can develop that together so that we can have models that Jake can talk more about that really marry those two.
I would say from my perspective, there are really two groups of people I would go after. One, and probably the most important of the two, is find the people who are feeling the pain of the negative outcomes today and bring them into the conversation. Right? We often begin working with folks that care a lot about a very specific issue, but they're not the ones that have the ultimate kind of financial accountability for that issue, that are paying for it today. But if you can bring enough of those people into the conversation, it can help to, what I said before, overcome some of those hurdles to actually getting something done, because you're reaggregating some of the diffusion of costs. The second piece, the actual building the pay-for-success type models, give me a call. There aren't that many of us that do this, but it's not rocket science, right? We're building performance-based contracts. And I think we've written a lot about how to do it without messing things up, which is pretty important. But we're a nonprofit. There are a couple others like us. Give me a call.
Great. Well, thank you. This is going to be we're going to stop here, but this conversation is ongoing, and I hope it will spark your most innovative ideas for partnering with us to achieve lasting change. And can I please have a final round of applause for this wonderful work? I certainly hope that you will continue to partner up with us and come to speak to us throughout APHA. Haluna Health is at booth 2120. Our team is here to answer any questions that you have. And we look forward to a wonderful conference, and thank you all for joining us tonight. Thank you to our staff, and specifically Nikki Kluge, who did a great job organizing this event, and our whole Haluna Health team. Thank you all very much.